nostalgic for you, right? No, head, face, and neck trauma, this is the cool stuff. This is like when you get on scene, you're like, oh shit. Because they look terrible, and you have to remember, most important thing when you see that oh crap scene is your BLS skills, right? ABCs. You start to forget some of that stuff when you see the scene.
Oh, you out of your way. Oh, did he got it going? Because of this.
It's because you clicked off.
There we go.
There we go. All right. So common major trauma. This is, 4 million people a year have head trauma. It's pretty common. Gunshot wounds to the cranium obviously have a high rate of mortality, right? I'm surprised that number's not actually a little bit higher, but some people survive those shots to the head. At-risk population for any kind of head trauma, obviously the most common reason why a male from 15 to 24 dies is because of trauma. Not necessarily head trauma specifically, but just trauma in general. And then that's why infants die, that's why young children die, that's why elderly die. Everybody dies except for the average-aged female from trauma. Because males are stupid and do stuff that are going to kill them. That's, my wife reminds me of this all the time, like I need a reminder. So there are injury prevention programs for all of us dumb males out there. I don't know if they're working. They're most likely not. Motorcycle safety. Motorcycles, it doesn't matter how safe the driver is, how good they are on the motorcycle. Are any of those accidents ever caused by the motorcycle driver?
Never.
Never. They're always caused by the car that doesn't see them, right? So it doesn't matter, just don't drive the motorcycle. That's what I tell everyone as an ER doc, seeing all of the crap that I have with motorcycle drivers, and you guys have seen the same thing, right? Who has a motorcycle in here? Dumb. Well, I have some neighbors with motorcycles too, and they keep trying, come on, Jake, get a motorcycle, we can be part of it. And I'm like, really? Like a 40-year-old motorcycle gang? Like, come on. But, so, yeah, I don't do that. I do other stupid crap. Sports, there's a lot of different, football technology coming out now, all the new helmets in football, all the new rules to try to prevent concussions. Youth football, it's becoming a lot more popular to do flag football rather than tackle football, padded tackle football, which obviously I would recommend. You don't want to expose a kid, especially that young, to that kind of sport, especially when, they're all kids and none of them are going to pay attention with how to hit. They've got a helmet on, they're going to lead with their head, right? So I would just not recommend having any of your kids play padded football until they get into high school, and then they can choose, right? Time is critical with any kind of head injury. The intracranial hemorrhages, just increased ICP in general. That increased pressure in the brain, it's a confined space, right? You have a skull. That brain can only swell so far, and then all of that swelling starts to constrict and shut off blood supply, no longer getting oxygen or blood to the brain, and that's where you get in trouble. And depending on how much time is involved with that increased pressure is where you get the permanent damage from. Severity, obviously, is difficult to recognize because you can't see the swelling. It's all based on how the patient looks and those subtle signs that can tell you what kind of pressure is going on and what kind of injury they have in the brain. This goes over the bones. These are kind of your basic bones. You guys don't have to memorize the the bones that make up like all of the orbit and your basal skull, ethmoid, lacrimal bone, sphenoid bone. You guys don't have to worry about those. But I want you to know the big, obvious bones. These are the ones that you are going to see with different kinds of head trauma. Parietal bones, obviously, Those are the biggest bones on the side. Frontal bone, temporal bones. Out of all of these facial and cranial bones, which one is the thinnest and weakest? It's important to know. Temporal. Good. Temporal bone is the thinnest and weakest. What's also important with the temporal bone from a blood supply perspective? Somebody gets hit in the side of the head with a baseball, right, with temporal bone. What are you worried about? Middle meningeal artery causing an epidural hematoma. All right? And epidural hematoma, those are the ones where they're conscious and lucid, and then all of a sudden, because epidural, and we'll talk about hematomas a little bit later, but that's important to remember. Of course, you got the maxilla and the mandible, orbits, and you have all of those basal cranial bones that I'm not going to make it memorize, but obviously I want you to know nasal bone, occipital bone in the back. You guys can go over all that stuff. This is kind of more of that. Like I said, you guys don't have to worry about lacrimal, ethmoid. You don't have to memorize, the differences in the zygomatic arch. Just recognize that there are two parts of the zygomatic arch shared with the maxillary bone and the temporal bone. All right, so the meninges of the skull. This is where your CSF fluid is located. If you think of the meninges almost like that pericardial sac, right, where you have an inner layer and an outer layer, and there's fluid in between. That's kind of how the meninges work. There is the inner layer, which is the pia mater, and that's a very thin layer attached right to the surface of the brain, and it follows the sulci and the gyri of the brain. So it goes into the sulci and it covers the brain. It's like saran wrap on top of the brain. And then there's a space on top of that, and that's the arachnoid space. All right, that's where your CSF fluid is. That's where that arachnoid space connects to your spinal cord, and you have that CSF fluid. And then your outer layer is the dura mater, and that is the outer layer that's touching the skull. All right? Does that make sense? From the meninges layer. These other things, obviously, important to remember. You've got the cerebrum. It calls it the cerebral cortex, which is kind of the same thing. Cerebellum, that's where your balance and coordination is responsible. The medulla oblongata, basically what we want you to know is that that's part of the brain stem. And medulla oblongata is important because if you injure the medulla oblongata, that's where your centers of respiration and cardiac function are. So injure that part of the brainstem and stop breathing. Can't breathe. Your body just can't, doesn't have that function. Spinal cord, of course, you guys know about that. So inside the brain, this is kind of an example of the venous system and how blood is drained from the brain and goes out. This falx cerebri is a cartilaginous layer in between the two hemispheres of the brain. So this is a pure sagittal view. If you were to cut somebody sagittally right through the middle, you'd see this falx cerebri. You've got a big draining blood vessel right here and draining blood vessel right here, and it all comes down into the transverse sinus. These are dural sinuses, and that's how blood is drained back into your circulation from the brain. The reason why it's important to know where the falx cerebri is and the tentorium cerebelli is because when you get increased ICP, intracranial pressure, because of a hematoma, say it's a subdural or an epidural hematoma on the side of the brain, pushing the brain over, right? If that gets too big, and there's not enough space, it'll eventually push that brain over into the other side. That's called a herniation. And it can herniate over or under that layer of falx cerebri or under that layer of the tentorium cerebelli. Most common herniation is right under there. The brain herniates right under that tentorium cerebelli. It's called a Uncal herniation. You get all of a sudden you get a blown pupil on one side. That patient's herniating. That means that if you don't relieve that pressure quickly, a patient is going to die. Right? Herniation is bad, and you need to know the signs and how to tell when you're going to have a herniation. We'll talk about that later.
How do they go about relieving that pressure?
What's that?
How do they relieve the pressure?
Cut a hole in the skull and get rid of the blood. If there is not a hematoma and it's just pure brain swelling because of a severe concussion, or concussion that's become a diffuse axonal injury, DAI. Have you guys ever heard of DAI? We'll talk about that later. But it's basically when a concussion gets so bad that there's such significant swelling that starts to cut off blood supply. And it's kind of a diffuse injury where the whole brain has a problem. In those instances, what they have to do is cut a whole piece of skull off. Meaning they cut a whole big piece of skull off, remove it, let the brain swell. Kind of like when they cut open a muscle for a compartment syndrome, right? Compartment syndrome is a muscle that's expanding in a confined space. So they have to cut open the fascia. Do the same thing with the skull. Take a big piece of the skull off. Let the brain swell, let it do its thing, and then finally, after it goes back down, they put the skull back in. What do they do with the skull in the meantime? Sometimes they put it right in the patient's thigh. And they just hang out with a piece of skull in their thigh so it stays in their body and it's taken care of. Sometimes they put it like in dry ice or whatever. But most of the time they try to leave it in the body. I had a friend that got in a motorcycle accident. He had basically a severe concussion, DAI. It was a severe DAI. On a CT scan, it looked like he probably should not survive. They took a piece off. They let his brain swelling do its thing, and he came back. I mean, he had learning issues. He moved to Argentina so he could learn a new language, so he could re-stimulate his brain because he was slow. But he worked and worked and worked and worked and worked and stimulated his brain, and he's back to normal. He's a U.S. Marshal now. Very smart guy. But he was funny because when he had that piece of skull off, he had to wear a helmet everywhere he went. And I don't know if you guys remember that old SNL bit with Mike Myers and who was it? I don't know, but he was, why don't you wear a helmet kind of thing, He was a kid that his mom had to wear a helmet all the time, so we'd always make fun of him. Why are you wearing a helmet? And then when he'd take his helmet off, he'd have this big index because he didn't have a skull there, and you could see the ripples of his brain. It's crazy.
So we want to give any sort of like steroids or
so in any kind of brain or central nervous system injury, spinal cord or brain, in the past, and probably a lot of surgeons still do it, and trauma centers still do it, we would give a dose of steroids. It's kind of an anti-inflammatory effect. But the research, and there's 20 years of research that shows that it really doesn't do anything. A lot of trauma centers still do it. You guys probably still see it done. But the evidence shows that it really doesn't do anything in overall mortality or prognosis. So a lot of newer trauma centers, or I guess newer trauma docs and ER docs don't do it. But older docs still give steroids. That's all you record that dose. So, cranial nerves. I don't care if, I'm not going to show you a picture of this and point to an arrow and say, tell me which nerve that is. I just want you to know what the nerves do. All right? Because that's important for you. You're not neurosurgeons. You don't need to be able to recognize the nerve. You're never going to see that, right? If you do see it, that patient's dead, right? So, 1, olfactory nerve. This is smell. 2, optic. This is sight. Oculomotor nerve. If you remember, 3, 4, and 6 are all eye movement. All right? Oculomotor does pupillary constriction as well. 4, the trochlear nerve is superior obliques. That's just a special ocular muscle that moves the eye up and away. It's on a pulley system, but you don't have to remember all that. You just know 3, 4, and 6, eye movement. Trigeminal nerve, this the sensation of the face, but also does your chewing muscles, masseter and pterygoid muscles, and chewing. Abducens, that's another, the lateral rectus muscle is another muscle of the eye. Facial, this one is a big one, right? Cranial nerve 7, facial nerve it helps a little bit with taste, but the big thing is facial muscles. Right? That's why we do a lot of the stroke testing and having patients do different things with their face. You know, smile at me, scrunch your nose, lift your eyebrows, blow out your cheeks. That's all facial muscles, because there's a huge portion of your brain that's geared towards your facial muscles, and very common strokes obviously show that ipsilateral facial group. 8 is hearing and balance. So that's your cochlear and vestibular nerve is 8. So 8 is big for people that have gait problems, strokes that they have nothing else wrong, but they're walking with that wide gait and they have balance issues. And that's because it hits that cranial nerve, or that part of the brain where the cranial nerve comes from. Glossopharyngeal, I want you to remember that facial nerve is face muscles. Glossopharyngeal does have some facial muscles, but nothing that is important. But it is posterior pharynx and taste is kind of the big one for the glossopharyngeal. Vagus nerve. Vagus nerve is your big parasympathetic nerve, right? You take out vagus and you don't have a lot of parasympathetic stimulation to the heart, then your sympathetic goes crazy. So vagus nerve, when it gets taken out, causes fight or flight-like effect on the body. The accessory nerve, that's trapezius, sternocleidomastoid muscles. Hypoglossal is your tongue. They stick their tongue out. You know, if you have a stroke patient or somebody that has a brainstem problem, hypoglossals are taken out, but when they stick their tongue out, they'll go to the side, and they point towards the side of the injury. Facial bones, we talked about those. We'll talk about them a little bit later when we talk about Lefort fractures. You guys familiar with Lefort fractures? Not yet. You will be today. All right, mechanism of injury. This is going to be big on your test. Okay, I've been reviewing that test to make sure all the questions are appropriate. Mechanism of injury is important. Okay, understand that when you're assessing a patient for trauma, if you think that there's a possibility they could have hemorrhagic shock, anything like that, it's going to be important for you to remember the mechanism of injury. That patient looks great, but they were in a head-on collision at 60 miles an hour. You need to be concerned that this patient could have internal hemorrhage and could eventually have a problem, right? So you need to take them to a trauma center based on mechanism of injury, not necessarily based on what the patient looks like at that time. So blunt injury, usually your MVCs, assaults, falls is a big one, right? You guys take in patient after patient after patient that's 80 years old and fell in the bathroom at midnight trying to go to the bathroom, right? Penetrating injuries are your gunshot wounds, stabbings, explosions, clothesline. You guys know clothesline, what that term would mean? Yeah, like some kind of line that this patient ran into, steel cable, whatever. We see those injuries quite a bit in trauma centers. Scalp injuries, contusions, lacerations, avulsions, significant hemorrhage. So an example of, I had an old lady that was on Plavix. She fell in the bathroom, hit the corner of her head just near the temple, and she had an arterial bleed, just, and when she arrived to the hospital, she had gauze that was wrapped around, and it was just soaked in blood. What would be your best action in trying to reduce bleeding in that patient? Direct pressure, right? And how long do you have to put your finger on that thing? Yeah, until you get her to the hospital, right? Like when you start rolling in the patient, I want to see one of you guys with your finger on that bleeding wound. All right? Because if you roll in and the patient's got just a wrap and it's soaked in blood and she's dripping blood down her face, that's a problem, right? All right. So, but the trick to that is mechanism of injury. Sometimes you put your finger on there and you feel a little bit of movement, or you feel a fracture line, right? Then what are you doing? Then it's maybe get some gauze, light pressure, try to get some compression to stop the bleeding, but you don't want to put any kind of significant force on that wound, right? You don't want to be really trying to stop that bleed. You're pushing into the patient's brain, right? All right, scalp avulsion. So cover the open wound with bulky dressing, pat under the fold of the scalp. So this is where you've got a flap, right? Scalp flap. Scalps bleed like crazy, right? Can a patient bleed to death from a scalp wound? Absolutely. Happens all the time. I had a young, he was like 25, 26, that came in. He was attacked by an individual with a machete. He had a couple of extremity wounds where they were defensive blocking wounds to his arm, and he had a scalp wound, but no skull fracture. Nothing happened with the skull. He was sent to an outlying hospital first. It was an hour away from the trauma center. So they, treated him, gave him all sorts of blood, and then sent him to the trauma center. By the time he got to the trauma center, he was done. We could not resuscitate him because he had lost too much blood. And he only had extremity wounds and a scalp wound. All of that bleeding should have been stopped. That patient should never have died, right? If his family had any kind of medical knowledge at all, they could get a huge settlement for that, because that's easily treatable wounds. So a pinna injury. What's pinna? It's your ear. All right. So ear injuries sometimes are tough, but you place it in as close to anatomic position as possible to dress the wound. Ear injuries are tough because although the skin has good blood supply, the cartilage that makes up all of your ear has terrible blood supply. So ears heal bad. That's why you got all of those fighters with cauliflower ears with all that scar tissue. They don't heal well. And those hematomas weren't drained appropriately as they should have been. Because tough guys don't want to go to the hospital and wrestle ear, and they're just like, oh, it'll be fine, and then they live their whole life with a big cauliflower ear when it's been easily treated and fixed. So if you've got a skull fracture, that's a significant blow, right? That's a high mechanism of injury. Linear skull fracture, that's basically a crack in the skull, non-displaced. Depressed. So if you guys ever watch, I'm sure all of you guys have watched Braveheart. He comes in there with a horse, and he's got that big ball and chain, and just smashes that guy's skull. Yeah. And for just a split second, you can see that big depression in his skull. That happens. And that's when, that bone, when crushed, doesn't pop back out. So you get this depressed fracture. Those ones are very difficult to treat and basically require the OR. Can't do anything about it other than having a neurosurgeon go in there and reduce that fracture. Impaled object, obviously, that's obvious, right? something sticking in the head. Open fracture, that's laceration with a skull fracture, right? Because you can have a linear displaced skull fracture or depressed skull fracture with no laceration, not considered open, right? Basal skull fracture. So this is those bones that are in the middle of your skull, ethmoid, sphenoid, lacrimal bones, that make up the very middle of your skull. So you can get basal skull fractures without any real obvious head injury appearance. Somebody with a football helmet, somebody with a motorcycle helmet, somebody with a ski helmet, they get cranked in the head. They have a helmet on, so the rest, their head and face look great, but they've got basal skull fractures. How do you tell if the patient has a basal skull fracture? So they're going to have symptoms, concussion-type symptoms, right? Absolutely. Amnesia, confusion, lightheadedness, dizziness. What were you saying, Alex?
They might get raccoon eyes or battle sign.
So yeah, battle signs, perfect. Raccoon eyes, and you get the bruising at the mastoid, right? You can also get, if you're checking their ears, they have blood behind their eardrum or even blood coming out. You can also have blood coming out of the nose, and you wipe it with gauze, and it'll show a halo. What does that halo mean? CSF with the blood, right?
Would you see that with any basal skull fracture?
No, it doesn't have to be. So not every basal skull fracture is going to have CSF leakage, right? That's going to have to be a very specific fracture, like the cribriform plate has to be broken for you to get CSF fluid down to the, out to the, and the same thing in your ear. They'd have to break the petrous bone, the petrous portion of your temporal bone, which is inside, to get that leakage of CSF from the ear. But raccoon eyes and that bruising of the mastoid, is that going to be acute, or is that going to be delayed? Delayed. So are you most likely going to see that in a pre-hospital setting? Probably not. Most of what you guys are trying to figure out is going to be based on the patient's symptoms from a basal skull fracture standpoint. It's going to happen at about 1 to 2 hours. You start seeing that raccoon eyes and bruising of the mastoid, sometimes even later than that. Now, we're just talking about that. Battle signs. So, retroauricular ecchymosis, that's a fancy way of saying bruising of the mastoid behind the ear, right? And we talked about that. The raccoon eyes is the bilateral paraorbital ecchymosis. They got bruising all around the eyes associated with the orbital fractures. I've got some good hospital pictures of me in the ICU with big old fat raccoons. My wife likes to show them to me on a regular basis, especially now, ski season's starting.
You sure you really want to go up there?
Right. And at some point, Gary's putting me on the schedule to go over that whole thing. I've got some sweet pictures, but we'll talk about that later. So basal skull fracture, if there's a tear in the dura, that's when you get CSF, right? So if you got CSF and you got that halo sign, that usually means that you're worried about increasing ICP, right? That this patient is going to be having real issues within the next 30 to 60 minutes with their brain swelling and then affecting vital signs. So time sensitive. This is kind of a obvious statement from the National Head Injury Foundation, but a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. A direct insult is a primary injury, causes force trauma to the brain. Indirect is the secondary injury that caused by factors resulting from the primary injury. And we'll talk about that a little bit. But the direct injury is basically the hit to the brain, right? What would be an example of a secondary injury?
Brain smashing into the skull.
Okay, that is direct injury.
Like swelling and herniation. That's so far.
Swelling and herniation. Herniation would be a secondary injury, right? Where you get such swelling that it starts to push that brain onto the other side, losing blood supply. We'll talk about some of the secondary injuries as well, but it's basically the body's response to that increased blood pressure, and sometimes that causes a spiraling to make everything worse. We'll talk about those secondary injuries here in a little bit, but these are the direct brain injury types. This is the coup, is that direct impact where you've got injury right there to the brain. The contra coup is that brain sloshing back and forth, and on the opposite side you're going to have injury from that brain hitting the skull as it sloshes back and forth. So you got coup injuries and contra coup injuries. That makes sense. You've got space in the brain. Elderly people, they have more space or less space? Way more space. That brain has a lot more shifting, right? So when they hit something, they have a lot more contra Q. And they've got really brittle veins in there. So they get that contra Q with a lot more space inside their skull, easily tears those veins. We talked about before those venous sinuses that drain the blood flow. Those tear in the old people, and that's where they get those subdural hematomas that you might not even know until a week later because there's so much space in the brain it doesn't make a difference until it gets really big. Direct brain injury, again, focal impact. So this is your cerebral contusions, your intracranial hemorrhages. That direct impact causes direct and focal injury where you were hit, right? Or with that contra Q effect. The diffuse is your concussion. So these are when that patient is helmeted and they otherwise look fine, but they took such a bad hit to the brain that it's more than just a concussion. They get such increased swelling because of injury to the brain, so they have diffuse axonal injury, DAI, and there's categories of that. But when it gets so bad that that swelling gets so bad it just cuts off blood supply everywhere. It's diffuse, right? I had a guy that was drinking a little bit golfing, and you drink a little bit golfing, and then you drive around a golf cart, and sometimes that can be a problem. He was riding on the back of the golf cart, hanging on, and the driver hit a little bump, and he fell off. Hit the back of his head on grass going 20 miles an hour. It's not much of a mechanism of injury, right? He went to an outlying trauma center. They didn't recognize it. By the time he got to us 40 minutes later, he had severe diffuse axonal injury. Died. Fallen off a golf cart. His family came in. They beat the ambulance. They were like, just all jovial, joking around. Can't believe this guy fell off a golf cart, whatever, because when they saw him at the outlying hospital, he was talking. He had a little bit of amnesia. Seemed like a concussion, no big deal, but obviously was progressing, getting worse to that the outside hospital thought he needs to go to the trauma center. He needs help. He needs to get part of his skull lifted off, right? But it was an hour away. By the time he got to us, he was gone. Could not be resuscitated. And by that time, there was no point in taking any piece of his skull off. He had absolutely no blood flow to his brain.
How do you present that to you?
He was like GCS3. He was just completely comatose. And he was decerebrate, so he had decorticate and decerebrate posturing. So he was, just bearing down. And we got a CT scan of his brain, and you could not tell the difference between the white matter and the gray matter. It just was all gray, or it was all just kind of that in-between color, but there was no differentiating. And that's when you have, if you can't see any difference between white and gray matter on a CT scan, that is significant severe axonal injury. He had absolutely no sedation on board, and he was gone.
So, in the ambulance crew, he dropped off while he was en route.
Yeah.
Did they recognize that at all? Did they let you guys know?
They radioed in when they were about 20 minutes out and told us what he was doing. They recognized his posturing, but there was nothing that ambulance crew could do. Had nothing to do with that pre-hospital transport. Well, I guess inter-hospital transport. Or it really should have been recognized earlier by the outlying hospital. But even then, if they had recognized it, that patient needs a neurosurgeon, right? They could have called the neurosurgeon, and the neurosurgeon said, you know, I'm going to look at the CT scan. You need to do a burr hole. And so then the ER doc, who's never done a burr hole before in his life, has never seen a patient like that in his life, is like, oh crap, how am I going to do that? Get out the drill, man, because he's going to die anyway. But they didn't recognize that. They didn't even, you know, nothing was even tried. So.
Professional when he presented his first hospital, was the CT have shown that?
The CT scan showed a moderate diffuse axonal
So
injury at that time.
Based on that, they may not have known that it would progress to severe, or
Right. It was all kind of iffy. I mean, the CT scan definitely showed that the patient had more than just a concussion, more than just what his mental status showed at the time, and that this would likely progress.
repeat progressive CT scans to watch that. Is that
Yeah. So we got a CT scan as soon as he arrived as well, and obviously showed the severity of the injury, and you know, gave us confirmation of what we were seeing on physical exam. But I mean, that goes back to your physical exam, right? Your physical exam is going to be more important than numbers that you're seeing, and vital signs will become skewed in brain injury later, after the injury's already occurred, right? So that's not going to be your telltale sign. If you see, we'll talk about Cushing's reflex. You guys heard of Cushing's? You're not going to see those signs until that injury's already happening, already occurred. And then Cushing's is right when, you know, you've got like minutes, seconds to open that guy's skull up where he's going to die. Cerebral contusion is the, you know, blunt trauma, capillary bleeding into the brain tissue. Common with blunt head trauma. You get the confusion, neurologic deficit, personality changes, vision changes, speech changes, depending on which area of the brain was injured. And a lot of that results in a contra Q. So contra Q, classic example is a, you know, blunt force to the front. It's going to cause damage to the frontal lobe, personality changes. Contra Q in the occipital region, and that'll cause vision changes. So they'll have both. Epidural hematoma. This is actually a terrible example of an epidural hematoma because in their example it looks just like a subdural. And in real life it doesn't, right? So if you, on your slides or whatever, remember that epidural is more like that.
We don't have those.
You guys don't have those slides?
I do. I'm not very updated on my job.
you have to skip down.
Fasciotic injuries.
Oh.
Oh.
Sorry.
Now we're tracking.
You guys don't have my exact PowerPoints? I'll let Gary know and see if we can get you guys the exact PowerPoints. But so an epidural is more concave, right? So you're going to see all this pressure because an epidural is between the skull and the what? Which area? The dura mater, right? And that's what I was talking about before with the temporal bone and that middle meningeal artery that runs from the skull and starts to go in between that dura mater and the skull. You get a fracture there, it bleeds, and it causes that epidural hematoma. So this is bleeding. I just talked about that. Middle meningeal artery. So this is rapid bleeding. This is usually arterial bleeding. This is a big, fast bleed, not your slow venous bleed like the subdural. So epidural is the fast. You get, if it's obviously big enough, they herniate very quickly. That patient, my dad, we have a long generation of skiers in my family. my grandpa, Raby, who just died at 96 this last summer on July 4th, which was very poetic because he was a World War II vet in Hawaii for Pearl Harbor. So it meant a lot to our family. But anyway, he was the original skier in our family. He was like one of the first skiers at all of the Utah ski resorts. He skied those mountains before the resorts were there. He would hike and ski. So my dad skied all of his life. My dad was a ski patrol. My mom was a ski instructor my whole life. So we skied like 3 times a week. We'd miss school and go skiing like my whole childhood. But my dad had actually 2 friends that both died because of epidural hematomas skiing. This was before people wore helmets all the time. And back then, they would wear super long skis in order to go fast, right? So they were difficult to maneuver. So sometimes you get going too fast and you can't make a turn. And he had 2 friends that ran into trees while he was skiing with them. And they got up after hitting the tree and were like, what happened, whatever. They were lucid and then out. And that's classic for epidural, where you've got a normal appearing individual with an obvious head trauma, and then boom, they crash. That's the epidural. And that patient herniates very quickly. There's not a whole lot you can do about it unless they're very close to a hospital, and that can be drained very, very quickly. All right, subdural hematoma. See, this is epidural. That doesn't look too bad. That's close to what a real epidural will look like. This is the one that doesn't really fit. So a subdural is going to be more, it's going to look like almost like a moon, right? It's covering that space. It's going to come all the way up here like a crescent type picture. But this is bleeding in what space? Subarachnoid space, right? So yeah, beneath the dura mater, within that space. But that's above the pia mater, so you're in between. It's like a bleed into your hair. It's like a tamponade of the brain, right? And it's slow. So slow bleeding, and it can progress over days. And you guys see this all the time with old people. Their mental status starts to deteriorate after like a week, and the family's like, I don't know what's going on. Like, he fell in the bathroom a week ago, but he hasn't had any issues, and now he's all confused, and well, they have a lot of space in their head, and now they got a huge subdural hematoma. That's why we scan just about any old person that comes in with a head injury, right? Head and neck. Intracerebral hemorrhage. So this is a bleed inside the brain, right? We can't drain those. All we can do is relieve pressure that bleed is causing, so that you don't get too much herniation. You can see this midline shift. What's this? What's this line? Is that the falx cerebri? Gosh, you guys knew it. It's right on the tip of your tongue. But when you start to see that shift over to the other side, that whole brain is pushing over. That patient is starting to herniate. These people will present with stroke-like symptoms wherever that bleed is. I mean, it's a hemorrhagic stroke, right? Ischemic strokes and hemorrhagic strokes. Intracerebral hemorrhage is a hemorrhagic stroke.
And so the only difference would be maybe trauma-induced as opposed to like a rupture.
Both. You can have trauma-induced intracerebral hemorrhages, but you can also have spontaneous bleeds. A person who's not controlling their blood pressure, right? They get a bleed into the basal ganglia. It's the most common place. It's right in the middle of the brain. That's an intracerebral hemorrhage that's spontaneous because they're not controlling their blood pressure. Or they have, an aneurysm because they have genetically bad vessels. All of that kind of stuff. So, diffuse brain injury. So this is due to the stretching forces placed on the axons, caused by swelling, and those axons start to stretch and swell and twist. Concussion is a form of diffuse brain injury. Moderate DAI and then severe DAI. And these are kind of your examples. This is a normal axon. You get twisting and stretching because of swelling, injury to whatever area, and you can start to get shearing of that axon. And if that shearing becomes too bad, it destroys that axon, destroys any of those synapses. And then you can't, then you don't, I mean, axons is what makes up white matter, right? You destroy all of that white matter, and now it looks like all the other brain tissue, and there's no connection. Mild to moderate, this is nerve dysfunction without anatomic damage. You'll get your concussion type symptoms, right? Confusion, disoriented, amnesia. So that's why when a patient comes in with a head injury, we ask all of those questions, right? Did you lose consciousness? We ask family about repetitive questioning, looking towards amnesia. Obviously, we're checking the eyes and looking at the pupils. But in these kind of situations, it's very important to continually do physical exam. I mean, your whole transport, you should be continually examining that patient, right? Every couple minutes, you're asking him questions. You're looking at his eyes. Because that can get bad real quick. And you want to be able to see those trends, see those signs before it happens. So you can beat it and, of course, transfer that information so the hospital knows what they're dealing with when you're coming in. Classic concussion. So this is kind of that minor bruising of the brain tissue. The unconscious patient, that's more significant, obviously, injury in that concussion state. The RAS is the reticular activating system, and that is their sleep-wake. It's what controls you being awake or being asleep. So a patient that's in and out of consciousness, that tells you that that's a worsening state, worsening concussion. Other signs and symptoms, so unconscious or persistent confusion, loss of concentration, disoriented, amnesia, both antegrade and retrograde, visual and sensory disturbances, mood and personality changes. I don't know, seriously. My wife says that my days in the ICU, I told Joe about things that I have said in there. I did a lot of weird shit, and my mood and personality was changed. And my wife said that it was a couple of months before she felt like I was Jake again. What's that? Yeah, exactly.
Do you get nystagmus with concussions?
Nystagmus? If you had injury to the vestibulocochlear nerve, that cranial nerve 8, absolutely you can have nystagmus. That would be a very, very specific type of concussion.
Like just general concussions, you won't get that.
Yeah, general concussions you wouldn't get nystagmus. Nystagmus has to do with that, with your inner ear and that balance, right? So your semicircular canals have specific fluid in them that control your balance and can tell you, even with your eyes closed, if you're upside down, if you're sideways, if you're not. And if that gets damaged, then it's always sending signals to your brain that tells the brain he's upside down, he's sideways, and so you're always like this. And when you check the eyes, they have nystagmus because that brain can't figure out and focus where you're at because it's always telling you that you should be in a different position. That's why it's always going back and forth. So severe diffuse axonal injury, when you get to the point where you can't see the difference between the white and gray matter, it's a significant disruption of those axons, and they all start to die. That's high mortality rate. Prolonged unconsciousness, you get that Cushing reflex, you get the decorticate and decerebrate posturing. What's the difference between decorticate and decerebrate? What's decorticate? Right, flexing, right? The cerebral, right, you're extending out, perfect. What's the Cushing reflex? Do we remember as the increase in ICP, so you've got increased pressure in your brain in that space. What's that?
Cheyne-Stokes increases blood pressure.
What's Cheyne-Stokes?
That kind of disorganized breathing or rapidly followed by short shallow.
Good. Good. Why do you think you'd have Cheyne-Stokes? What's responsible for that? Part of the brainstem. The medulla oblongata. Good. So you've got increased pressure, and it's starting to push your brain into whatever space it has. One of the only holes, right, is that foramen magnum. So it starts pushing that brain and your brainstem down through that hole, permeates through there, and it causes that Cheyne-Stokes because your medulla oblongata can't tell your lungs to breathe right. The other part of Cushing reflex, as you're increased pressure in your brain, your brain's telling your body, I need blood flow. In order to overcome all the pressure in the brain, what does the body have to do to your blood pressure? So your blood pressure, especially your systolic blood pressure, starts to skyrocket, right? To try to overcome that pressure in the brain and try to get some blood flow to the brain. The diastolic doesn't. So you get a widened pulse pressure, right?
It's trying to push harder.
Right.
Blood up there.
So, well, it's a combination of reflexes because you've got all of those baroreceptors, right? In your aorta, in the atrium, in the carotid, you've got all those baroreceptors trying to control blood pressure. The brain's saying, I need more blood pressure, I need more blood pressure. And then you've got all of those forces telling the baroreceptors, this is way too much blood pressure. We need to start to, so you get this big widening pulse pressure because your body's trying to do two different things, right? And the bradycardia. So that's another effect of those baroreceptors, is you've got this huge blood pressure and your heart's going, wait a second, this is way too high, and so your heart starts to decrease. And we'll talk about kind of the details of why that happens. So we talked about this. Your cranial volume is fixed, right? 80% is actual tissue. Cerebrum, cerebellum, brainstem. 12% is blood vessels and blood. 8% is CSF. So if you start to get swelling in one of those, your brain compensates by decreasing the others, right? We don't want to decrease blood flow. So most of the time we're trying to decrease the CSF to create a little bit more space. And when, that's obviously you don't have a whole lot to work with, so it doesn't take long before it can't compensate anymore. And then your ICP just starts to increase because you can't do anything about it. So as you're compensating, it's compressing the venous blood vessels, trying to make more space, right? Reduction in the CSF is pushing the CSF down into the spinal cord, again trying to make more space. It's not doing it good enough, and you get this increased ICP. Increased ICP results in an increased blood pressure. That's that Cushing's reflex to perfuse the brain. That further increases the ICP. You just go in this circle. It's just getting worse and worse, right?
So, otherwise, you just no longer able to have the veins pump blood out of your skull, but the arteries are still able to pump blood into it? Or?
Well, it's trying to do both. So your body is trying to get blood into the brain through the arterial system, and then the brain is trying to get blood out. So it's just this, it's spiraling. So as it's pushing blood out, it's still working. I mean, your venous system's still working until it gets so high that blood can't get anywhere. But it's just a spiraling effect. But you're still doing both. If that answers the question. So the role of carbon dioxide is why we put patients on capnography, right? And we want to see what their end-tidal CO2 is and what it's doing. So as you increase CO2, that causes cerebral vasodilation. If you've got vasodilation, what's that doing to the space in the brain? It's taking up space, right? So in order to reduce or what's the word I'm looking for? Counteract, there we go. In order to counteract that vasodilation, what is the body going to do? Try to get rid of that CO2. How's it going to get rid of CO2? That's where the Cheyne-Stokes comes in, right? You get all these different signals. It's like, okay, we need to get rid of all the CO2 to prevent any of this vasodilation and have some vasoconstriction when you have reduced levels of CO2. But if you get too vasoconstricted, what does that do? You got no blood flow, right? You get anoxia. So the Cheyne-Stokes, where you get this hyperventilation and then nothing, right? Because the body's like, oh wait, that's way too much CO2 we blew off. Now we're going to make you stop breathing until that CO2 ramps back up again, and then I'm going to make it. But there's no coordinated effect.
So when we intubate, what should we be trying to keep CO2 levels at? Should we be hyperventilating?
What is it? What do you want the end title to be? In
35 to 45.
an injury, in a head injury patient.
I think 30 is
30.
what we're supposed to be at.
You want to sit at about 30 to 35. But that's for a short period of time, right? Because if you do it for a long period of time, what happens? You're blowing off too much CO2, and you get vasoconstriction, and that causes overall diffuse brain injury, right? So that hyperventilation should be a short period of time,
So
30 minutes.
30 minutes?
Yeah.
So we should like alternate between like 30 minutes of hyperventilation and then let them the CO2 come back to normal ranges
Yep.
for another 30 minutes or just thereafter.
You know, it depends on how long your transport is and how.
Yeah, right. Probably.
You know, if you're transporting for an hour or two, then yeah, I would. You know, we usually do 20 minutes, or 20 on, 20 off. Some neurosurgeons will say hyperventilate for 20 minutes and then done. Then I want normal end title. So sometimes it depends on who the trauma surgeon is, who the neurosurgeon is, who the ER doc is. But in those situations, I would call and get some help. All right, so vascular constriction. So with your systolic blood pressure, low blood pressure, obviously you have poor perfusion. High blood pressure, you get increased ICP. So what do you want? You've got a head injury patient. What do you want their blood pressure to be at?
Enough to provide perfusion to the brain.
Good. So 90 systolic is a pretty good number. Now, if the patient themselves is climbing and their blood pressure is going way up, can you do anything about that? Not a whole lot, right? Other than check pupils, call in, say, I think this patient's herniating, right? So this is the spiraling effect. Cranial insult tissue edema causes increased ICP, really compresses the arteries, decreased blood flow, decreased O2, brain cells die, edema around the necrotic tissue obviously increases more pressure, compression on the brain stem and the respiratory center, CO2 accumulates, you get vasodilation again, increased ICP again, increased blood volume. I mean, it's a bad situation.
I'm sorry, I'm asking like every single question.
Oh, you're fine.
So would you suggest treating that hypertension with like MAG or like diltiazem, something that will lower their blood pressure over a period of time, or?
No,
Okay.
because why is that blood pressure climbing? It's trying to overcome the brain swelling, right? If it can't overcome the brain swelling, are you getting any blood to the brain? If you try to decrease that blood pressure, what are you doing? You're killing brain tissue. There's no blood flow to the brain anymore. So what can be done? From your perspective, not a whole lot. Drive fast, right? You can try to maintain that end tidal CO2, make sure that they're oxygenating. Obviously, make sure they have a good enough blood pressure that they're having perfusion to organs. But if that blood pressure is climbing, you start to see that Cushing's reflex, drive fast.
Can we get liking?
It's not going to do anything. All right. let's see. So this is we're just talking about the herniations here. So it herniates, brain stem down through the foramen magnum. This is what kind of injury does that look like? Epidural, right? More of that concavity, not convexity. So upper brain stem, patient starts vomiting. They don't even feel nauseous, but they're vomiting. They're altered. They have pupillary dilation. Pupils are blown. Why do the pupils blow? Which cranial nerve controls the pupillary muscles? Close. 2 is vision, right? 3 is muscles. So 3, 4, and 6 control muscles. The reason why you get blown pupils is because it's compressing that cranial nerve 3. All right, that's controlling your pupillary constriction. And if there's no pupillary constriction, where is the ganglion or the nerve center controlling the sympathetic portion of your eyes? Close. It's outside of the brain, right? That's in your neck. So you get brain swelling. It's compressing what's controlling vasoconstriction. So there's no vasoconstriction anymore because that cranial nerve 3 is out, and you get blown pupils. Because the sympathetic one is still sending signals, and it's the only one left. So all you have is dilation. All right. Let's see. We talked about the altered mental status. Cushing's reflex, increased blood pressure, bradycardia, erratic respiration, it's called the Shane-Stokes. Vomiting without nausea, you get projectile vomiting. Body temperature changes. What happens? Body temperature wise. You have kind of a systemic vasoconstriction, right? Your body's trying to increase its blood pressure to overcome the ICP. So you got this system-wide vasoconstriction. So the patient is cold, ashen, pale, looks like death. All right. Frontal lobe injury, we talked about that. Personality, occipital, visual, cortical injuries. This is where you get your amnesia, and then focal deficits. Depending on where that brain injury is, you can have stroke-like symptoms, weaknesses, you have seizures. We talked about this, brainstem compression, vagus nerve stimulation. So if you get brainstem compression and you're herniating down through, not only is your blood pressure up because it's trying to overcome the ICP, but you also take out the vagus nerve. Vagus nerve is responsible for what part of this nervous system? Parasympathetic. So you got nothing contradicting what the body's trying to do, and then your blood pressure goes way up anyway. Now, you guys don't need to memorize the differences between upper brainstem and middle brainstem. Just know what happens when the brainstem starts to get injured. Let's see, bilateral pupil sluggishness. So that's important because the blown pupil is obvious, right? Patient gets a blown pupil, you're already too late. They're already herniating, right? But if you're doing constant physical exams on that patient, checking the pupils, and you notice that their pupils are starting to get sluggish in their reactivity, that's when you can really start to recognize that here in the next 10, 15 minutes, we're going to be in real trouble. And that's when we can recognize, okay, this is a significant head injury. We talked about all that stuff. That's my wife. I don't know why she's calling me all the time. Yeah, she knows I'm here. What's that? I do have Earth, Wind, and Fire. I'm actually a real big fan of Earth, Wind, and Fire. That's my wife's ringtone, is Earth, Wind, and Fire. When we're out on the boat, that's like our boating song. Is like 3 or 4 of the Earth, Wind, and Fire songs. Love it. All right. Cushing reflex, lowering level of consciousness, singular or bilateral dilated pupils, and you get the posturing. There's no movement to painful stimuli. Glasgow Coma Scale, you guys know GCS, right? You guys can recognize GCS. That's going to be important. I guarantee you on your test, they're going to ask you what this patient's GCS is multiple times. The way I like to remember it anyway is going from top to bottom. Top, eyes, that has the 4 points. Then you get to verbal, that's your mouth, that has 5 points. Then you get to the body, that's movement, that's 6 points, right? Because for me, sometimes I forget which one has the 5, which one has the 4 points, which has the 6 points. So I start from top to bottom. So in older patients, obviously a little bit different pathology because they don't have as much. Oh, wait, no, we're talking about pediatric patients. Also different pathology. They have the fontanelles. The fontanelles help actually prevent a baby with significant head injury because it creates a little bit more space, right? Those bones are not ossified yet. They can expand out. Fontanelles have a little bit of space. You get bulging of the fontanelle. If you get bulging of a fontanelle in a pediatric patient, that means what? That's trouble, right? Drive fast. In pediatric patients, they can lose significant amount of blood with head trauma. So in adult patients, you can't fit a whole lot of blood in there, right? Holy cow. How many slides we got left? All right. But in a pediatric patient, you can fit a lot of blood in their head. And their head is, I mean, in some pediatric patients are as big as their body, right? With pediatric patients, you want to avoid hyperextension of the head. And of course, you want to ventilate through the mouth and the nose, especially infants. They do, most of their breathing is obviously nasal, right? So the Glasgow Coma Scale is just a little bit different for pediatric patients, and it's mostly because you can't get a correct exam on a pediatric patient. They can't speak, verbalize anyway, so you have to understand it a little bit differently. Grunting is bad. If all they're doing is grunting but they're not responsive, that's bad. If they're uncontrollably crying, that's going to be low on your verbal score. Let's see here. So we talked about this. Cranial nerve 3, oculomotor nerve. This is pressure on that portion of that cranial nerve 3, and you get sluggish pupils. When it gets really high pressure on it, you get those dilated blown pupils. We talked about that, sluggish pupils. There are, obviously situations where it's very difficult to get a correct physical exam. Alcohol, drug use, some of those things that are going to affect the pupils anyway. So is this heroin overdose or ICP, right? Facial soft tissue injury, you guys talked about this with Joel a little bit, well, extensively, so I don't need to go into it a whole lot, but there's a lot of blood flow to the face and scalp, so you can lose a lot of blood with injury to the face and scalp, right? Big thing with facial injuries is making sure you're doing your ABCs, check that airway. Patient's gurgling, what are you going to do? Suction, right, write that down. What if, you don't suction? and you put a mask on and you start bagging the patient, what are you going to do? You're just pushing a whole bunch of blood into his lungs, right? Blood is very irritating in the lungs, causes edema, and you're going to be in big trouble. Any kind of facial fracture, facial injury, obviously you want to consider a facial skull fracture. Make sure you're checking and being aware of the signs that would indicate that. Check my text. I just want to make sure that I don't have like a kid dying or something like that. All right. So facial fractures involving the maxillary and nasal bones, they're going to be Lefort fractures, and we'll go through the different kinds of Lefort fractures so you can be aware of them. Big things to look for is involvement of the zygoma and maxilla, because the maxilla is that inferior orbit of the eye. Any kind of reduction of eye movement, as you're doing tests on the patient and they have reduction of their eye movement, that's compression possibly posteriorly behind their eye on those muscles, and they're not able to have regular eye movement. Diplopia is what? It's double vision. So you don't have appropriate eye movement, and so you can't appropriately focus, and you get that double vision. A limitation of jaw movement obviously will indicate a mandibular fracture and possibly that joint. So Lefort fractures, basically what you want to remember is Lefort 1 is through the maxilla, all right, bilateral. Lefort 2 is maxilla and nasal bones, all right. You got a test question that says, which fracture goes through, or what kind of Lefort fracture goes through both maxilla and nasal bones? That's Lefort 2. Lefort 3 goes through nasal and orbits, but there's the maxilla. All right?
Can you say number 3 again? Orbit and maxilla.
Orbit and nasal is Lefort 3. Lefort 2, maxilla and nasal. Lefort 1 is maxilla. Can you guys find these slides?
Yeah,
It's just hard to find sometimes. Nasal injuries, rarely life-threatening. What do you not want to do in a traumatic facial injury from an airway perspective? Don't shove anything through the nose, right? No nasal trumpets. Good. You guys don't do nasotracheal intubations anyway, right? Don't you? Is it on skill sheets? That's sweet. Like possible anaphylactic patients or something like that. It can be useful.
I've got a question on that.
Yep.
As you do the blind stuff on their vocal cords, how much trauma can you do? We had a patient that had spasms from a bad invasion somewhere back east.
Mm-hmm.
I don't want to cause that stuff, but if you're poking that tube right at those cords, how much can you do from damage?
Yeah, you can. Absolutely. Vocal cords don't heal very well because they're cartilaginous, and you can definitely cause permanent damage if you're, popping through the vocal cords with that tube.
Blinds or blind invasions, something that anybody would do. Aside from
There are certain tricks. Sometimes if you push the tube on the vocal cord, and there's two things. When you put pressure on a vocal cord, it'll stimulate it. It'll stimulate and dilate. So if you put a little bit of pressure and then advance, you can get through without causing too much damage. You can also, depending on the consciousness of the patient, wait for an exhale. The patient exhales, those vocal cords are open, you can push it through. That's especially useful if you're not wanting to do a paralytic, like on an anaphylactic patient, their throat's starting to swell, you need to intubate them awake. Nasotracheal intubation, you can't see the vocal cords, so you do that thing. You can touch, stimulate, and then push through, or you can wait for an exhale and put it through. All right? And you'll know on an awake patient if you've intubated the esophagus or the trachea, because they'll let you know. All right, we're going to take a 5-minute break.
Oh, that's okay.
Yeah. It's, you know, or kind of trips it up. I should have done it, but that's turn them off. Yes.
Did you work out? Good job. Thanks for working out, friend.
24.
Yeah, why do you guys have cancel? You're done at midnight.
Maybe that's
I just had to force myself.
I have to. But she gets tired.
Unless I have to work.
Like, I'm trying to study. Okay. Fuck study.
It's like the first one, you're like, no, I'm still studying. Yeah, I'm good.
Yeah. This is a good
And your dad leaves.
That's a good story right there. So
Oh, we did. Yeah. We had actually done an about but big old green auger. Guy felt they didn't have the guard on it. Guy felt to it. Feel it. Yeah. Take the guards off and duck grease all the time.
oh,
And then you guys can wait before we do the next one. But it wasn't even that big of an emergency. So you guys know I've been trying to plan some kind of warm trip for my wife so that she doesn't have to be home in January. And we've got a whole bunch of guys from that were in the avalanche as well, going with us and their wives, and I kind of put this thing together. And my mom and my sister are like, "Why didn't we get invited? We want to go."
Were they in the avalanche with you?
So that's my wife saying, "Take care of this right frickin' now, because your mom and your sister are not coming." So I had to be me.
Are you taking them skiing?
Exactly. So, and you know, the vacation is for my wife, and she doesn't want my family to be there. As I don't, you know, imagine. I can't imagine why not. But plus, for me, I don't want my mom there because I want my wife to wear as little as possible. And she won't do that if my mom's around. All right, eye injuries. Is this where we're at? But if we skip over some stuff. Okay, we're there. Ear injuries. We talked about that. Poor blood supply to the cartilage, so you don't get very good healing. Skin will heal, the cartilage underneath won't. That's why we almost always give antibiotics with ear injuries to try to prevent infections because they easily get infected. Internal ear is well protected from trauma. The petrous bone, although the temporal bone is weak, the petrous bone is very, very strong where your internal ear is. Those get injured with like diving injuries, blast injuries, explosions, where you get that pressure against the tympanic membrane. And tinnitus, does anybody know what tinnitus is? Ringing of the ears, good. That can be permanent if you've got damage to that area. And tinnitus is basically a signal from that vestibular cochlear nerve going to the brain that your brain can't make sense of anymore because there's injury there. It's always sending kind of these weird signals, and your brain just interprets that as ringing. Something's going on. This is what I'm going to tell you it means. Penetrating trauma of the ear. Basically, don't remove any foreign object. Right? Leave that in. Let the surgeon do it. I don't remove it either, unless it's something that I can easily get from the external canal. But if there's any kind of real penetrating injury, I leave it alone. Let the surgeon do it. Corneal abrasions and lacerations, those are obviously very common, right? Corneal abrasions, people scratching their eye, even burns. You can get sunburns. People in tanning beds can get corneal abrasions. The most common, or I shouldn't say most common, but very common, is welders that don't put their mask on. Get those flash burns on their cornea. Hyphema, what is that going to look like? You'll see a puddle-looking thing in their anterior chamber of the eye, meaning the anterior chamber is what's over top of the color of the eye, the iris, right? And the hyphema is where you'll get blood in front of that iris, and so you'll just see this puddle-looking thing on the anterior portion of their eye. And that generally happens from blunt trauma, injury that anterior chamber. Subconjunctival hemorrhage, what does that look like? I have these bilateral. So all the whites of your eye is blood. So oftentimes with bad subconjunctival hemorrhages, you won't see any white of the eye. It'll just all be blood. Some people will just have little spots where they get blood, and they're like, oh my gosh, sometimes that can happen spontaneously. Most of the time it's because of trauma. We see them a lot with tennis players. They get hit in the eye all the time with tennis ball. But you can get spontaneous ones just from increasing your pressure to your head and your eyes. Strong sneeze, coughing, vomiting, or trauma. So that's a subconjunctival hemorrhage. You just have blood where the sclera is. That's a hyphema, where you get this puddle-looking thing. This is a really bad abrasion with a laceration. So that yellow. So the yellow is. You guys know what the yellow is? Yeah, it's the fluorescein dye that we put on the eye, and under blue light, you can see any kind of abrasions or injury to the eye. They've had trauma, they've got a laceration. You can see this flap of eye, and that's inside. They're draining a little bit of fluid in that anterior chamber. They've got significant lacerations here. Acute retinal artery occlusion. That's a stroke. It's a stroke to the eye. Right? You get a blood clot. It goes to a blood vessel of the eye. The retinal artery, and you basically have loss of vision. Painless loss of vision. Oftentimes it's stroke. Most of the time it's a stroke.
It's a pretty fast thing.
Yeah.
Looking around, so.
Retinal detachment is that the patient described it as like it says here, like a curtain over the field of view, where it almost shades down, it pulls over the eye, but that's where the retina on the back of the eye detaches, usually from trauma. Again, I see that with baseball players, tennis players, get hit in the head and get a retinal detachment. Sometimes with wrestlers that get slammed down. General injury to the eye. Cover the injured eye and the uninjured eye. Why do you want to cover both eyes?
Because if they got something sticking around this one, you cover it, but this one's still open. You should be looking around.
Right. One eye moves, the other eye moves, right? If they look at something that even just light, the pupillaries constrict, that'll cause the other one to constrict just the same. So anything they do with one eye, it'll happen with the other. So you cover both. Sterile dressing. Don't ever put any significant pressure on the eye, right? Corneal abrasion. For you guys in the pre-hospital sense, you don't try to take. You guys are not trying to take out any foreign object to the eye, right? So this, remove with normal saline moistened gauze. Unless you can see a foreign body moving, and you have the numbing solution, I would suggest that you don't try to take out any foreign body from the eye, because it's going to be very, very difficult. A bolster, impaled eye, cover and protect. General care, obviously the patient is going to be very anxious. You want to try to keep them as calm as they can so that they're not moving their eye. Blood vessel trauma, neck injury. So blood trauma, you get that serous hematoma, laceration, sanguination of, obviously you have very significant blood vessels in your neck and it can bleed out very easily. But it's important to cover. I want you guys to remember this. If you've got any kind of penetrating injury to the neck, you want to cover it with an occlusive dressing. Why is that? Because you don't know with that penetration if that affected their airway at all. And if you've got any kind of fistula between vessel and airway, they breathe in and that'll suck air into the blood vessel and they get air embolism. Stroke out and die. So you need to cover with an occlusive dressing any kind of neck penetrating trauma. Let's see. Airway trauma, obviously, tracheal or larynx. You have to be careful with edema and mass effect on the airway and get control of that airway before it's too late, right?
Real quick, with the knife in the throat, would you try to do like an occlusive dressing and then stabilize it?
With the knife in the throat, where the object is still there, you can try to wrap and stabilize as best you can, but that would be the goal. You're not necessarily trying to cover the wound because it's already blocked with the object. Obviously, you want to make sure that that does not move, right? You just want to stabilize and mobilize that object.
So it's not that guy who swallowed. Like any kind of swallow.
Right. Good. You want to try to keep him as calm as you can, obviously. If there is an airway compromise, I would suggest in something like that, you don't try to intubate. Obviously, if they need an airway, they've got blood, everything else. You suction and stick in an eye gel. But I wouldn't try to intubate and put anything through the trachea if there's suggestion that their foreign body is there as well. All right?
If they hit where you would cry, just pull it out and cry there.
That would be pretty ballsy. If it was already gone and you saw air coming out through the wound, that's an idea.
Do I get credit for it if I pull the knife out? I mean, do I get credit?
Oh yeah, you get the Crike credit.
Okay.
And you get the huge huevos credit. All right, so spine fracture, vertebral fractures. You know, obviously we know what happens if you injure the spinal cord, right? All of these things below the level of the injury. Neurogenic shock. What's neurogenic shock? We'll talk about this a little bit later in a future lecture in more detail. But neurogenic shock means that you've just taken out the nervous connection from that level down to the rest of the body, right? So you have no sympathetic innervation to any of those blood vessels from the site of injury down. What happens if you have no sympathetic innervation? Vasodilation. So where does your parasympathetic innervation come from? Which part of the spine?
The
Vagus is true.
cervical, sacral.
Cervical and sacral, right? So you got no parasympathetic innervation coming out from thoracic lumbar spine all the way down. That's all sympathetic. So if you have an injury to the thoracic or lumbar spine, everything down from there, you get vasodilation and hypotension because there's nothing controlling that vasodilation. You get neurogenic shock. So how do you treat that? They also don't have any connection to the adrenal medulla that's supplying norepinephrine and epinephrine. So what do you need to supply? Dopamine or epi, right? You want to replace what it's not getting and cause some vasoconstriction. And you'll find that neurogenic shocks, those are the easiest shocks to treat. You give that pressor and boom, you're good, as long as they weren't in shock for too long. Sometimes it can trick you though. Just real quick, if you've got an injury to anything past T4, you get a blood pressure on the arm, and what's it going to be? Below T4, anything below T4, that blood pressure on both arms is going to be stone cold normal. Might even be elevated because the body's trying to compensate for all the vasodilation going on underneath. So you're like, you don't even need to treat this blood pressure, right? Right, that one's hard. What you need to do is be aware if they're not feeling and don't have any motor function to their legs, you're worried about possible neurogenic shock, right? So you need to be keeping track of the other factors going on. Urinary output. Obviously, for you guys, you're not going to be able to record urinary output or anything like that. You can get a pressure in the leg and check it, and yeah, it'll definitely be different. Your ankle pressures will be different. All right. Neck trauma. Obviously, you get subcutaneous emphysema. That's the Rice Krispies, right? You guys all felt that? When you get air underneath the skin, and you push the air because the air is going into the soft tissues underneath the skin. Because either tension pneumothorax and air starts to push through the tissues and it's all underneath the skin. If they're sitting up, they start to get air up their neck, and when you push on their skin, it feels like Rice Krispies, sounds like Rice Krispies. That kind of crackling and popping. But yeah, it is. The subacute air. It's not as painful as you would think, but it's certainly not comfortable. Tension pneumo. Traumatic, or what happens with tension pneumo? Good. What happens with your blood pressure?
Blood pressure goes up. Or
blood pressure goes down. Why does blood pressure go down with tension pneumo? Yeah, you've got increased intrathoracic pressure pushing on the heart, decreasing your preload, right? All right. Vagus nerve disruption, we talked about that. If you disrupt the vagus nerve, you get sympathetic drive, right? Thyroid and parathyroid glands. You guys know where the thyroid is. You get penetrating neck trauma, and you're like, oh, it didn't even hit the airway. It's pretty superficial. You can get quite a bit of bleeding from the parathyroid thyroid because it's got a lot of blood flow. It's releasing hormones into the bloodstream. It's you can bleed out from a thyroid injury. So sizing up the scene, you always want to make sure what's the mechanism of injury, right? Your primary assessment, airway, breathing, circulation. You guys have already gone through primary, secondary assessment, right? All that stuff. So how long should your primary assessment take you? Yeah. Minute or two, right? Rapid trauma assessment, head, face, neck, GCS score, vital signs. Secondary assessment, how long is that going to take? That is continual, right? Detailed assessment is, after you go through your physical exam, then you're really looking at the details. You're really making sure that patient has all their clothes off and looking at all the details once you've stabilized and taken care of everything else. Most of the time, you guys are at the hospital before you have to worry about those things, right? You're worried about life-saving measures in these kind of situations. More Glasgow Coma Scale, you guys know this. So this just goes along with this is ABCs. I can't believe you guys did nasotracheal innovation. It's super bad. Digital innovation. Have you guys ever thought about digital innovation? What's that? Yeah. Where sometimes you have facial trauma, they need an airway. You try to put a blade in, and you're just moving mandible and causing more trauma, getting more blood. So you got to stick your fingers in there. Suction, fingers, get it through the cords.
So with the severe facial trauma patient that's blown the front of their face off with a shotgun, would it be better to go in with an ET tube and try and tube them, or just go straight to the crank? Because if they're going to get reconstructive surgery, are they going to be working around the tube, or are they going to?
They obviously will be doing surgery around the tube. They'll probably, that patient will probably, depending on the severity of the injury. So, ENTs and maxillofacial surgeons work around ET tubes all the time. That's what they do. They're surgeons of the face, and none of those patients get cracks or trachs, right? If it's a patient that's going to have an airway for a long time, then they'll go ahead and put a trach. If they think that this patient is going to have an ET tube for more than 2 weeks because of their significant injuries and brain injury and everything else, then they'll put a trach in, or they'll put a trach in. But otherwise, they'll stick with an ET tube. And we put them in all the time with facial injuries. Sometimes you get so much blood, you get the suction in there, somebody else is suctioning all they can, there's still too much blood, and you just tube them where the air bubbles are. All right, you guys have crack kits, right? Crack kits make it better. Breathing, ventilations, one of your goals obviously is maintain that end-tidal CO2. And after you've intubated, you want to hyperoxygenate before and after, right? And then you can get into a more baseline respiratory status depending on how that ET or end-tidal CO2 looks. But that initial hyperoxygenate is important, both pre and post. Circulation, obviously, control bleeding, right? You want a blood pressure, food resuscitate to 90. We talked about that. Hypoxia, we want to prevent hypoxia, right? Hyperoxygenate, hyperventilate, and then hyperventilate. After intubation, we talked about that as well. If there's not a herniation concern, you can return to the normal ventilations. If there is a herniation concern, you hyperventilate for a good 20, 30 minutes. Call in and say, hey, how long do you want me to do this for? Hypovolemia. You don't have enough volume, you're not going to have perfusion. You'll have hypoxia to the brain. So you want 2 large bore IVs, and you want your blood pressure, that systolic, to be above 90 in an adult, 80 in a child, 75 in a small child, 65 in an adult. Oxygen. Is this the... I'm going to be back. I'm going to go ask Gary something real quick that I forgot to ask him before. We might not need to go through all the slides. Gary? Quick question for you. All right, good. I love that. Because there's a whole bunch of medications at the end of this part of pharmacology that we don't need to, you guys don't need to go through right now. It's part of this lecture. But for oxygen, you know, this first-line medication, high flow oxygen, hyperventilate, reduces the CO2 levels. Respirations, you guys know that, 12 to 20 times per minute. You want to keep the sats above 90, 95%. 15 liters of oxygen, that's just part of the hyper oxygenation. So medications, we don't need to go through all this. This is just talking about different medications that can be used, but you guys will learn about these later. Furosemide, succinylcholine, what's that? Depolarizing paralytic, good. And again, you guys don't need to go into this. I don't even think, do you guys even use intracranial? You guys don't even have that, right? That's similar to vecuronium. You guys don't even have. You guys don't have pancuronium either, right? You guys have Beck and Rock. You guys don't have diazepam, but you do have Versed, correct? You guys know about that. And obviously, this is not going to be tested. You guys don't have to worry about the medications. More thing, fentanyl. Important note on fentanyl is that it's very potent, and its onset is very quick, and it causes muscle rigidity. So you give too much fentanyl too quickly, and you get what's called chest syndrome, where the muscles controlling respirations all lock up, and they can't breathe. Very scary for the patient. Seen it. So sometimes with fentanyl, from a practical sense, I know that you guys go off of milligrams per kilogram, but with fentanyl, I like to choose doses based on more age than weight. So pediatric patients get 12.5 to 25. Adult patients get 50 to 100. I have never given a patient more than 100 milligrams of fentanyl. I've seen that pre-hospital all the time, and I always worry about chest syndrome. Because, you know, you get these huge obese patients, and you want to treat pain based on ideal body weight, not necessarily their 200 pounds over ideal body weight, right? Because their respiratory muscles are working just about the same as the person who's just as tall as them, but not quite as obese. Etomidate, atropine. Let's see. All right, yeah. Transport considerations. Anybody that has a head injury, you want to limit stimulation as much as you can. Keep them calm, dark, not a whole lot of noise. You know, limit your conversation with your partner to whatever you need to do, but you want to decrease the stimulation as much as you can, because that'll increase ICP, and stimulation in those situations can cause them to seize. That's one reason why head traumas are iffy with air transport. Not only do you get the pressure differences, but there's a lot of stimulation involved with helicopters and planes. emotional support, if you can get family involved, a family member that's calm involved that you think will have an effect on the patient, that's important. If they're the opposite, you want to make sure that they're not part, and that you get them removed so that they don't make the patient any more anxious. This is a summary. You guys know, I'm just kidding. This is a really crappy summary. But it basically just says what we just did. Oh, we're done. You guys go eat lunch. And we'll be back, I don't know, whenever Gary says. 40 minutes? What do you think?
Yeah, sounds great.
1 o'clock.
Yeah, 1 o'clock. Did I not start it again?
Nope, perfect. That.